Hi, my name is Peter Sabatini, and I'll be presenting with Graeme Quest to discuss some technical and practical considerations when using NGS panel for CLL in a diagnostic type set. CLL is a mature B-cell malignancy that can sometimes remain indolent, but can also cause severe disease that might require treatment. So there are recurrent genomic lesions that can be found in mature malignant B cells that predict disease outcomes. So specifically, 13q deletion might confer a less severe disease course, whereas the ATM or TP53 deletions predict a worse outcome. In addition to these prognostic informations, genomic variants also predict response to treatment. So unmutated IGHV, TP53 deletions, and also TP53 sequence variants don't respond to chemotherapy, but will respond better to treatment with kinase inhibitors such as ibrutinib. So to detect the genomic changes, numerous tests might be used. Traditional FISH or microarray was used to look for deletions, and NGS used to detect sequence variants such as TP53. And importantly here, NGS has improved to a point where we can now detect both copy number changes and sequence level variants. So we chose to look at the performance characteristics of this next generation sequencing panel from OGT called SureSeq, CLL, and CNV panel. And this contains targets for 12 genes relevant to CLL, including some genes resistant that confer resistance to kinase inhibitors, such as the PLCG2 and BTK. And also will detect copy number changes in 5 chromosomal regions that include those 4 that I had mentioned: 17p over TP53, 11q over ATM, the 13q, 6q, and also trisomy 12. So what I'll show here are just some highlights of our validation studies. And what we did was we ran 33 blood and bone marrow samples with CLL. And we also had 24 normal peripheral bloods that were used as a reference for the CNV column. What I'll show here is for CNV, I'm going to focus mostly on the limit of detection. And we had a known sample with variants at 5% that we ran in duplicate to look at the reproducibility of these variants at that lower level. And in our experience in a classic NGS panel, 5 to 10% is typically a reliable limit of detection, and we were interested to look at the performance of these at this panel at this level. And the copy number variants, we compared the NGS results to the FISH cell counts for all the 33 samples that we had run, and we have FISH results for the 4 loci I mentioned: ATM, 13q, chromosome 12, and TP53. So most samples achieved a mean target coverage of well over 500 when running 16 samples on a MiSeq. So the 2 points on the right here, these are actually the same sample, and they're a bit of an outlier in terms of mean target coverage. One of them was quite low, and in uniformity of the NGS results. So I will come back to this interesting case at the end to just illustrate the importance of mean target coverage in interpreting the NGS results. So when looking at the SNVs, or the small or single nucleotide variants, the limit of detection about 5 to 10% does require high coverage. So we had this one sample that we had 2 variants that we know are at 5%, confirmed by another NGS panel. ATM, a small deletion, and TP53 is a missense change. So the first run was at a lower mean read depth, and each of the variants were detected at 2 and 3.5%. And the second run, we have a higher mean depth, and the allele fractions are closer to what we'd expect, about 5 or 6%. So if we plot the allele fractions of all the variants found from this sample in both the runs, you can see that the ones in blue are the variants, the ATM and the TP53, and the ones in red are known artifacts or false variants. And all the artifacts fall well below 5%, and only the real two variants above 5%, and above 1,000 read coverage. And so ensuring sufficiently high coverage around 1,000 or even 500 for these, and over 5% will limit the false positive reporting. But variants between 5 and 10%, actually, we were interested to know if these occur quite commonly. So what I'm showing here are the list of variants from 5 to 10% from our complete validation set of 33 samples. And we found a number of samples, 10 samples, had I think 11 different variants between 5 to 10%. And these variants are clinically relevant, and some of them even recurrent, like the BRAF or the SF3B1 variant shown here. And so variants between 5 and 10% are common and important to detect. Looking at the sensitivity of the copy number changes, what we ran the 33 samples, some in duplicate, with various abnormalities found by FISH, and compared these to the normal reference of 24 peripheral blood samples used for the baseline copy. And you can see that we had a number of normal that were detected accurately at the 4 different loci, and then many positives that were also detected. And the false negatives all represent that limit of detection. So these were all below the limit of detection of NGS that FISH was able to detect, and I'll show these in more detail. And then this one false positive, I have a question mark, which I'll show in more detail at the end. Chromosome 12, it was only the long arm of chromosome 12 that was detected that represents more of a low read depth that might have resulted in a false positive couple. And I'll show that in more detail later. So when we plot the mean log2 ratios from the NGS panel on the y-axis to the net genomic change established by the FISH cell counts at each loci for ATM, TP53, 13q, and chromosome 12, you can see that the mean log2 ratios and the net genomic change are relatively correlated. As the net genomic change gets larger, so does the mean log2 ratio. And if we zoom in on the 0 to 40%, you can see that all the false calls shown in the circle here occur below a net change of 25%. So the limit of detection here for the NGS panel is between, we say, 25 to 30%. And we can accurately or reproducibly detect them above that 25 or 30%. And the smallest CNV that was detected in the validation set was at 13q of a 676 kb deletion. So finally, I'll just highlight this artifact that we had come across for the chromosome 12q gain. This sample was normal by FISH at chromosome 12, but had a number of other abnormalities by FISH, so 13q loss, TP53 loss, and actually an ATM gain. So it represents a relatively complex signal pattern. by FISH, and this sample was run twice, one with a higher read depth and one with a lower read depth, and it was the lower read depth here that generated that long arm 12Q gain that we consider an artifact or false, and we attribute that to the lower read depth and possibly a little bit to the complexity of the genome of this sample. So this highlights the importance of sufficient mean coverage to generate the most accurate results. So to summarize, the limit of detection for CNVs is about 25 to 30% and 5% for SNVs. And we aim to have about 1,000 mean target read depth to ensure quality results. And we will maintain FISH for some cases, especially for TP53, to ensure those lower level losses are not missed if necessary. So I'll now hand it over to Graeme Quest to discuss some of the practical considerations. Thank you.
Thanks, Peter. I'm Graeme Quest. I'm a hematopathologist at Kingston Health Sciences Center, and today I'll be talking about practical considerations for the OGT SureSeq CLL plus CNV panel. Over the past 25 years, our knowledge of the molecular genetics of CLL has grown exponentially, particularly with regards to the prognostic and predictive impact of IGHV somatic hypermutation status, copy number abnormalities, and somatic mutations. Numerous studies, including CLL8, demonstrate a roughly threefold increase in TP53 aberrations in patients with IGHV unmutated heavy chain status, and the finding that TP53 deletional loss is really just the tip of the iceberg for TP53 abnormalities, with roughly 30% of TP53 abnormalities missed by FISH alone. The 2018 IWCLL guidelines indicate that genetic testing should be completed prior to treatment, particularly as the prevalence of TP53 abnormalities is recognized to increase at later clinical stages, and particularly after progression following chemoimmunotherapy. General guidance would be to pursue genetic testing for predictive value upon the development of anemia or thrombocytopenia that would indicate Rye3/4 or Benet-C clinical stages, or in the presence of active disease, which might be portended by the absence of cytopenias, but bulky adenopathy greater than 10 centimeters, splenomegaly more than 6 centimeters below the costal margin, B symptoms including night sweats, unexplained weight loss or fevers, or a brisk lymphocyte doubling in less than a 6-month period, or perhaps also with refractory paraneoplastic autoimmune syndromes. The most recent IWCLL guidelines suggest a reporting threshold of 10% for TP53 variant allele fraction, with variant allele fractions below this threshold having an uncertain clinical impact. Though subsequent publications have raised concerns that even at lower VAF may be associated with inferior survival, especially when treated with chemoimmunotherapy. As indicated by the IWCLL guidelines, there's a definitive role for genetic testing prior to every line of therapy for both its prognostic and predictive roles. Testing for IGHV somatic hypermutation status separates two broad subsets of CLL patients. While CLL with a mutated IGHV status has an overall prevalence of approximately 60% of CLL patients, CLL with unmutated IGHV tends to demonstrate more aggressive behavior and a higher probability of progressing to requiring treatment. As such, a greater proportion of patients at later clinical stages, Rye3/4 or Benet-C, demonstrate unmutated IGHV. Patients with mutated IGHV and with wild-type TP53 are predicted to have an excellent response to chemoimmunotherapy, whereas unmutated IGHV predicts inferior event-free survival and overall survival in response to chemoimmunotherapy. This is largely overcome through treatment with a Bruton tyrosine kinase inhibitor or BCL2 inhibitor. The presence of TP53 abnormalities predicts poor efficacy of chemoimmunotherapy regimens and indicates a relative contraindication to their use, with greatly improved progression-free and overall survival in response to BTK inhibitor or BCL2 inhibitor regimens. Though there still is a higher risk of treatment failure relative to TP53 wild-type cohorts. The proportion of patients with TP53 abnormalities, del17p or TP53 somatic mutations, increases with advancing clinical stages. TP53 abnormalities are expected in approximately 8.5% of treatment-naive IGHV mutated patients, but at a nearly threefold higher rate in treatment-naive individuals with unmutated IGHV. As such, genetic testing prior to first line of therapy can differentiate the roughly 37% of Ry34 Benet-C patients expected to have an excellent response to chemoimmunotherapy, those with mutated IGHV and no detected TP53 deletions or mutations, in contrast to the 63% of patients who will present with unmutated IGHV and or TP53 abnormalities. These patients will demonstrate a markedly improved response to non-chemotherapeutic regimens, such as first-line BTK inhibitor therapy. TP53 abnormalities are further enriched in relapsed and treatment-refractory populations, with frequencies of up to 40% in these subsets. This warrants repeat testing prior to any subsequent line of therapy so that the most effective choices can be made. In virtually all hematologic malignancies, deletional loss of 17p, including the TP53 locus, is recognized as a very poor prognostic and predictive factor, though detection of FISH markedly underestimates the frequency of total TP53 abnormalities, as illustrated by Stengel et al. Notably for CLL, testing by FISH alone would be predicted to miss approximately 40% of patients with TP53 abnormalities, while use of somatic nucleotide variant detection alone would be expected to miss approximately 10% of affected patients. This emphasizes the IWCLL guidance that detection of both TP53 somatic variants and copy number abnormalities is required as standard of care. Based on this, several different variations of monoallelic or biallelic TP53 loss can occur, either based off of deletion of 17p alone, more commonly mutation of one copy of TP53 with loss of the other allele, or mutations involving one or more TP53 mutations on one or both TP53 alleles, including mutations with copy-neutral loss of heterozygosity. Through these variations in TP53 abnormalities, somatic variants would be expected to be present in approximately 90% of affected patients, while copy number abnormalities would be found in roughly 70%. As Dr. Sabatini discussed, confident detection of copy number abnormalities, including TP53, using the OGT SureSeq CLL plus CNV panel, is seen at genetic fractions greater than 25%. In the context of expected frequencies, several groups, including a Canadian center, have demonstrated that roughly a third of patients with 17p deletions detected by FISH are expected at levels below this threshold, typically with a worse prognosis at higher cell fractions. So what does this mean for the clinical utility of the assay? Thankfully, we have good data to help support our assessment of the clinical impact. It's helpful to consider that the ultimate goal of detection of any TP53 abnormality, which will then direct therapy independent of whether it's an SNV, CNV, or both are present. So it's a bit of a Swiss cheese model. As long as either is detected, we'll successfully determine the appropriate therapy for the patient. In treatment-naive, IGHV mutated Benet-C populations, a total TP53 abnormality rate of 8.5% is expected. As Dr. Sabatini illustrated, confident detection of SNVs down to 5% VAF is possible with adequate read depth. So detection rate of 100% is expected for the proportion of patients including somatic variants. While the presence of TP50 deletion below 25% is unfortunately rather common, a CNA detection rate of roughly 67% is expected. While this certainly raises alarms, the overall impact is significantly muted by co-interpretation with SNV status. As we expect only about 10% of the population to be deletion of 17p without somatic variant, and only approximately a third of these to have a cell fraction of less than 25%, we would estimate an overall false call rate of TP53 wild type in less than 3 in 1,000 IGHV mutated Benet-C patients tested. Approximate accuracy expected of 99.7%. Outstanding. While TP53 abnormalities are approximately threefold more common in IGHV unmutated population, the net effect of CNA detection sensitivity is still markedly muted by successful detection of SNVs in this population. In this subset, the estimated false call rate of missing a TP53 abnormality is still less than 1 in 100 patients. While an expected accuracy of slightly more than 99% is very good, it's still concerning that this would potentially misdirect therapy in 1 in 100 patients affected. This concern is significantly offset by the fact that first-line therapy with a BTK inhibitor is funded for patients independent of TP53 status. As final thoughts, the CLL 2018 guidelines mandate assessment of donor classification, TP53 mutation status, and IGHV somatic hypermutation status as standard of care. The presence of TP53 abnormalities is a predictive biomarker for poor response to immunotherapy and overall survival. For patients with TP53 abnormalities, the CLL and Cancer Care Ontario guidelines indicate first-line therapy with a targeted non-chemotherapy agent is preferable. The frequency of TP53 abnormalities increases with clinical Rye-Benet stage, with IGHV unmutated status, and particularly in patients with relapsed and refractory disease after chemoimmunotherapy. Frequencies as low as 4% in IGHV mutated early stage CLL can be expected, or up to 40% in patients with relapsed refractory disease. TP53 abnormalities frequently include both SNV and CNVs in about 60% of the population with TP53 abnormalities, but may be somatic variants only in approximately 30% or copy number variants only in about 10%. The use of integrated testing for both TP53 SNV and CNVs represents a significant potential process improvement, ensuring that both SNV and CNV testing is ordered on every patient and one is not missed. In turn, integrated reporting of SNV and CNV status represents a further process improvement whereby clinical interpretation errors could be reduced, preventing, for example, misinterpretation of somebody with normal FISH but a somatic variant present as normal based on the FISH result, or likewise mistakenly referred to as TP53 wild type for the absence of SNV mutations while missing a possible copy number abnormality reported separately. The OGT CLL CNV panel has an expected accuracy of greater than 99% for treatment-naive CLL for detecting TP53 abnormalities based on sensitivities of 5% for somatic variants and 25% for copy number variants, as illustrated by Dr. Sabatini. While further validation is definitely indicated, this is very favorable, and certainly raises the question whether FISH testing is required for all cases, or indeed any. This could represent a significant reduce in workload and testing costs for the OGT SureSeq CLL plus CNV panel versus combined testing of TP53 sequencing plus FISH. As such, we believe the assay has a tremendous clinical and lab impact, and we're very excited to continue the validation. I hope this has been helpful, and we're happy to take any questions either online or by email.